That was really an excellent talk, very challenging subject. So I'm going to ask both of you, Dr. Bristow, Dr. Masch, to thank you, to show up on screen. Actually live here, we have our moderator, Dr. Annie Alanzi. This is her second time at one of our gynecologic cancer conferences. And Dr. Alanzi is a gynecologic oncologist. She lives in Houston, Texas. She's the founder of a fantastic international organization called Potawira International. She is also assistant professor at Texas A&M and Weill Cornell, as well as the director of gynecologic oncology at Houston Methodist Hospital in Willowbrook. And Dr. Alanzi is going to be facilitating the Q&A on these very interesting and difficult talks, both on incredibly challenging questions that we face as gynecologic oncologists and as people navigating these issues.
Okay, thank you very much. This was a very stimulating, interesting conversation. So I'll just go right to the questions. I'll start with Dr. Bristow. So most patients, when they go to the operating room, despite, conversations about, potential bowel surgery, they don't really want to wake up with a ostomy, and especially in situations where maybe a patient has had a major surgery already, and then postoperatively they suffer complications of a bowel perforation that was probably not noted during the surgery. So when you take those patients back to surgery, how do you contend with that desire of giving the patient what they want that will feel less complicated, versus, approaching with giving the patient, maybe a temporary ostomy? And then how do you discuss this with the patients after, as they deal with the challenge of maybe having to live with a temporary ostomy?
Yeah, thank you. It's a great question. This comes up on a daily basis with our patients, because anytime we go to surgery, there's a potential for a complication. And you can't always predict when things are going to happen and when there's going to be a need for some sort of a diversion or an ostomy. But in my practice, I review all my own preoperative imaging. And so I can usually get a pretty good gauge for what the likelihood is that we'll need to do a bowel resection on a patient. And if that likelihood is moderate to high, then we have a conversation with the patient about what they want us to do in the event that we have to do a bowel resection and we can't get things back together. Do they want us to leave the cancer behind and not do a stoma, or would they prefer us to get all the cancer out and do a stoma, which might be temporary, it might be permanent? And I'm a big fan of drawing pictures, cartoons for patients to try and help them understand what the challenges are that we're going to be facing during the surgery, and having to reroute plumbing and what the purposes of a resection and a stoma would be, just to generate a shared level of understanding with the decisions that we're trying to make. And usually, if you're willing to sit down and spend 15 minutes with a patient and have an honest conversation about what it is that they want, you'll have a pretty good understanding of what decision algorithm they want you to follow in the operating room. But I will say, if there's any confusion about what to do during the surgery, I will ask the patients beforehand if I can talk to their family members to help make decisions intraoperatively if we are at an inflection point in that decision process. And that has worked out very well too, because the family knows the patient better than we do. And they have a better sense of what the patient will and won't tolerate. So knock on wood, I haven't been burned using that strategy yet, where the family has recommended something that the patient didn't want. But that's kind of how I address it.
Great. And then another question is, when a bowel injury occurs during surgery, how do you decide what patient is a good candidate to just have a primary repair? What kind of injury would that generally be? Or what patient may require bowel resection based on what the injury was and to what extent?
Yeah, that's a great question. So the answer is it depends. It depends on the location of the injury, the type of injury that it is, and the extent, how big it is. So the type and the extent are probably the most important things. So if it is just you've nicked the intestine with the scissors or a scalpel, and it doesn't extend more than halfway circumferentially around the bowel, and a primary repair will not result in a significant narrowing of the intestinal lumen, then primary repair is almost always the way to go. The complicating scenario is if you've got a thermal injury from some sort of electrosurgical instrument, you can't visually appreciate the extent of damage to that tissue. And so you either need to re-resect some margins of normal appearing tissue around that injury, which will naturally make your area of injury bigger. Or the simpler thing is just to resect that limited segment of bowel and put things back together. That is the safest way to approach the thermal injuries, I found. Yeah.
And there was another question from Laura Gregerson. Dr. Bristow, you mentioned that there's an increased risk of a bowel obstruction with scar tissue, and that timely recognition can result in a simple repair. My question is, what observation will you see if scar tissue buildup in the small intestine is occurring and a bowel obstruction is imminent?
Yeah, it's not always the same, but usually you'll see, so it can be either it's either going to be some sort of treatment related or disease related. The treatment related ones are probably more common. And the best example is probably the radiation damage to the small intestine that we see in patients who've received pelvic radiation therapy. So the intestine wall will be, instead of a healthy pink, it'll be sort of a dusky gray color. Instead of a supple consistency, it will be hard, kind of like leather. And you'll physically see a narrowing of the lumen of the intestine. It's just not as capacious as the intestine is that hasn't been in the radiated treatment field. And then obviously, if you see a backup of intestinal contents above the area of potential or impending obstruction, that is going to be a pretty good indicator that that there's an obstruction likely. And then from post-surgical adhesions, it's kind of the same thing. You'll see intestines that'll be stuck to each other or stuck to a certain area of the abdomen or pelvis with damage and scar tissue. Again, that change in the from healthy pink to abnormal white or gray color, and a narrowing with a backup of contents behind. Those are pretty good clues that if you don't do something now, you're going to have to do something pretty soon.
Thank you very much. Dr. Masch, thank you for covering a very challenging topic and doing that so objectively. So, I'm in Texas, which is one of the states that lit up red from your presentation. So, in restrictive states like this, how do you provide patients information? How does a provider navigate through providing information for patients on what their options are?
Yeah, that's a great question, and one that we are learning how to handle right now. Texas got a little bit of a jump start with SB 8, Senate Bill 8, before the Dobbs decision came down, which closed down essentially the last clinic in Texas. And a lot of the most restrictive laws are coming out of Texas, actually trying to make medication abortion, for example, illegal across all state lines, everywhere, not just in the states that have restrictions. So our colleagues who are there are facing difficult decisions where they, because there is some SB 8 allows for vigilante justice, which allows for anybody who is seen to be helping or aiding someone to get an abortion, including, for example, the Uber driver who brings someone to a place, can also be implicated and fined and even imprisoned. So it is a tricky legal landscape to navigate, but there is a lot of support in trying to help those clinicians get trained. What I didn't mention, so there's so much in this question, but what I didn't mention was that in those states that have banned abortion, it affects not only patients and providers, but trainees. So we're essentially now not allowing people to learn how to do these potentially life-saving techniques And so UCSF, when SB8 came down, UCSF started a training program for providers in Texas. And there are other such programs that are going to be going through the states, because we have complex family planning fellows who need to get trained in this this is one of the hallmarks of the fellowship itself. So trying to set up training programs in those states that are protective for abortions, that people in states that have restrictions can access. So there are websites, there's meetings, there's getting patients out of Texas to nearby places like Colorado that are much more, have much more access to reproductive health care. And I think, Annie, that we are at the beginning of trying to address the enormous challenges that this decision brings to reproductive health care and women's access across the country. So, and things change, as I mentioned in my talk, things change literally sometimes week to week and day to day. And so it's difficult to keep up with all of the different legal restrictions, and then the bans that get overturned and the bans that then get put in place. And so it's really something that one has to pay attention to on a daily basis, practically, to be able to ascertain what the legal landscape is like on that particular day.
Yeah.
So challenging for sure.
So I had, like, as you say, things change day to day. I mean, I think literally probably 4 days or 5 days after the decision was made, I actually had a patient that came in that my nurse practitioner had seen through the ER. I know, like on a weekend, it was like a Saturday, and had a viable, pregnancy at 18 weeks, but also a molar pregnancy. Her HCG was, close to 1 million. She had hypothyroidism. Her blood pressures were elevated, and she was tachycardic. And so it was one of those things where we were trying to decide, on the spot, what we were or were not allowed to do. Because at that point it was unclear, what I could do as a physician, and whether or not I was even allowed to speak of it. And so, what are the sort of like advice you would give to physicians as you're contending, with these decisions of what you say to patients? And there could be a nurse listening in that decides that that's inappropriate and would like to report. And what are the sort of like immediate available sort of like sites where you can go and say, what are the laws today in Texas? And what can I say today in Texas? Because essentially this patient had to wait a week for a committee to meet and decide what was actually appropriate for her to have done.
During that week, she could get substantially worse. Her condition could definitely get substantially worse and make it harder to give her good care. To answer your last question most directly, you can call the ACLU of Texas, which you can have, they have people on standing by, and there's a national line I can share with you, and those on this, I can send out links to try and get to someone who can tell you what the legal landscape looks like and what your options are at that time. Sometimes, though, you have to get to, I think in this situation, it sounds like your hospital needed to decide, right? Because the hospitals themselves can have their own rules and restrictions. Even if it's allowed in the state per se, the hospital can decide to be more restrictive and decide not to be able to give that care. So you also need to speak to hospital administration, and perhaps if there's an ethics committee in your hospital. I mean, it really puts a chill on healthcare provision and good patient care and the health of women. There was a woman who sent out a TikTok video while she was in Tennessee, and she was saying that she was just diagnosed with an ectopic pregnancy, and she was in terrible pain, and she was making this video from the emergency room in Tennessee. And she was saying, I'm in terrible pain. There's a possibility that my life is in danger, and my care is now not being decided by doctors, but being decided by lawyers. And ectopic pregnancies, as most of us know, are never going to be viable infants. It is really, it's taking a a pregnancy and making it more important than the person who is carrying that pregnancy, who is a viable individual and a person. So it's really, it is very scary. It's a scary landscape, but there are, we're formulating plans and trying to bring up the resistance and figure out how we can best help women across the country, because those of us who are in states that are more protective really need to, we are banding together to figure out how to help our colleagues and women across the country who don't have access to these life-saving measures. I mean, it's really insane.
All right. Thank you both very much. Appreciate your time, and I'll turn it back over to you.
Okay. Yes. Thank you both. Very much appreciate it. We have just a few minutes longer before, but I wanted to see if either of you had anything else you wanted to add based on the conversation. Dr. Hardesty, welcome to join in. And obviously members of the audience, if you have any last questions before we say goodbye to these fantastic panelists.
I do have one recommendation of a video that people can watch if they're trying to, Amy Schumer, who has a video about Come to Colorado. It's about 2.5 minutes, and it actually is worth a watch, I think. So I was debating whether to put it in this talk, but I'm leaving it up to each individual to do it on their own. But I recommend it, and it is a sort of gets to the heart of the matter a little bit, but it has humor involved too. So I would, if you just Google or search for Amy Schumer, Colorado, it should come up. It's a 2 minute and 40-something second video. So something that can help you understand some of the issues, but also do it in a way that can maybe make you smile, even though it's such a serious subject.
And I would just add that every time I've taken care of a patient who has a desired pregnancy and then comes into me with a cancer diagnosis, and we are literally faced with a question about what to do to help preserve this woman's life versus manage or make good decisions about a pregnancy that may be desired. In these cases, most of the time, these are initially desired pregnancies that come to me, and then we find cervical cancer or we find an ovarian cancer. These are tremendously hard decisions to make just on that level without any other challenges about what the legal choices are. They're very, very hard decisions and and cases to manage. So I think it's really important that we're able to talk these things through with each other. Even acknowledging the divisiveness of the issue in terms of how do we approach these questions to help our patients make choices for themselves and navigate these tricky times. So thank you so much.
Yeah, in the unit I run, I would say 80% of the patients who come in with desired pregnancies that have some kind of an issue or a problem. That's not, depending on where you are, it's different landscape, but those are the people I take care of, and completely emotionally devastated by a diagnosis of a pregnancy that has an issue or problem or is no longer viable for whatever reason. And it's really, it's already such an emotionally fraught situation. And then to put such legal limitations and take it out of the relationship between the provider and the patient is just, it makes an already completely horrible situation even so much worse,
Well,
thank you so much. Dr. Bristow, any last words from you? Thank you for doing this.
No last words, but just to pile on, I'll tell you, as a chair of an academic department in an abortion-friendly state, it's such a divisive issue. It's not always friendly. Like even within our institution,
Definitely.
it is just it's maddening. Like just having labor and delivery nurses that will refuse to provide care to a patient who's having an undesired miscarriage because it's a quote unquote abortion is it just wants me to stick, I want to stick pencils in my eyes.
Somebody's eyes.
Yeah, somebody's eyes. But yeah, I think I just wanted to offer that perspective that even though we're in California, in Southern California, like the battle for women to be able to make decisions about their own bodies probably never ever going to be over. And this is, this sucks, but it's probably just a speed bump and one of many speed bumps. And we just got to redouble our efforts and get back at it. That's all I just wanted to say that.
Thank you.
All right. Well, thank you, Dr. Alanzi. Thank you, Dr. Bristow. Thank you, Dr. Masch.